All right, we'll start in 1 second. Just waiting for everyone to join in. Can everyone see the screen? Is it blocked at all? Betsy, Dylan, good? Okay. Thanks. All right, we'll go ahead and start. And it's pretty open registration, so people can join in. And this is being recorded, so we'll share this on our site afterwards. So just as background about documenting COVID and the Brown Institute and MuckRock, we all work for documenting COVID-19. It's a project that was grant funded out of the Brown Institute for Media Innovation at Columbia and Stanford. And then we got sort of, oh, and the data repository, thanks. Betsy is including in the chat the data repo, which is a Google Sheet, and then the CDC data itself. But a little bit of background, we started at the Brown Institute, now we're with MuckRock, which is a public records journalism website. And Dylan, Betsy, and Mohar have been working with us for months on various projects surrounding the pandemic. The latest project we're working on with the USA Today Network is Uncounted, which is a look at CDC mortality data, death certificates, and the issues with death certificates, which for decades it's been understood that as many as 20 to 30% of death certificates are have inaccuracies or errors in them. And in the pandemic, that's only been made worse. So we've dug into that, talked to coroners and medical examiners and public health experts and demographers and statisticians to figure out what is missing, why deaths go uncounted. We've talked to families as well to figure out sort of the obstacles and hoops they've had to jump through in order to get those death certificates fixed. And now we're coming out with a larger project on this and hoping that local newsrooms and journalists will take some of the lessons learned and tips and apply it to their local communities and report on some of the patterns and trends and issues that the new CDC mortality data from their aptly named API CDC Wonder provides us. So we'll go ahead and start, and I'll have Dylan, actually, if everyone could just briefly introduce themselves, Dylan, Betsy, and Mohar, and then Dylan will start.
Sure, I'll go first. I am Dylan Bergen. I am a senior journalism fellow with documenting COVID-19 and MuckRock. I've also been leading a lot of this reporting in the last few months for the Uncounted series, working with reporters in Mississippi and Louisiana and Missouri, as well as with Andrew Stokes, a demographer at Boston University, who I think is on this call, but who's been modeling excess deaths at the county level. So that's it for now, but we'll be talking more about all those things throughout this webinar.
I can go next. I'm Betsy. I'm also a senior journalism fellow at Documenting COVID at the Brown Institute in MuckRock. I'm a science and health journalist who's been focused on COVID for the past couple of years. In addition to my work at the Documenting COVID project, I run a newsletter and blog on COVID data, the COVID Data Dispatch, and I freelance for various outlets. And I was also a longtime volunteer at the COVID Tracking Project, which is where a lot of my expertise in these numbers comes from.
Hi all, I'm Mohar. I am a senior research and data fellow at Documenting COVID. I'm also a graduate student in computer science and journalism at Columbia University. I've been working in excess deaths for a while, but I started contributing to Uncounted a few weeks ago. A lot of my expertise is in drug overdose deaths and now in nursing home deaths. So that's where I come into this project.
So I'll just hop into this first slide. So I guess a lot of our reporting starts with the question of how many COVID deaths have we missed, have we underreported. A lot of you on this call as journalists or just as people interested in COVID data have probably heard over and over again the term excess deaths, especially in relation to drug overdoses and deaths for external causes. So one kind of big thing that started this investigation, or one kind of pivotal avenue that we've gone down, is keeping in mind these external deaths that are often kind of the subject of news coverage, whether that's drug overdoses or homicides. These are the types of deaths that may have increased during the pandemic for reasons related to the pandemic, but were not directly from COVID. So I've kind of been thinking about that all along as, because of COVID in some way, but not from COVID. And so when we're talking about excess deaths and the type of excess deaths we're interested in, it's always been the ones that were actually from COVID, and the ones that have gone uncounted, which throughout the last few months, some of the biggest reasons we've seen that to be are choices by local medical examiners and coroners, the really difficult process of filling out a death certificate, and the fact that there's still a lot of confusion on how that works and how that is done, even by highly trained medical professionals. I've had multiple physicians tell me, I signed my first death certificate when I signed my first death certificate, which was when I was finally practicing and no one was there to tell me how to do it. It's just someone died. I may have been, in the ER overnight, got called up, ran up there, and had to figure out what to do with this document. Because obviously there's so much focused on people before they die, that last really important piece of information, the death certificate, is not maybe given as much attention as everything that happens before that. But then there are also the more pandemic related scenarios, especially early on in the beginning of the pandemic. There was limited access to testing, especially post-mortem testing. And there were also, especially in the first few months of the pandemic, really there was uncertainty about the clinical manifestations of COVID to begin with. So these all kind of make, especially in the first few months of the pandemic, recording COVID deaths really difficult. And then there are also deaths that occur outside the medical system, what we've done a lot of reporting on, and which I'll kind of talk about later on in this webinar, and the political pressures that come with the people that are signing those death certificates. So not all death certificates are signed by physicians. A hefty amount are also signed by coroners, who are elected officials and often lack medical training. So that's kind of the way that we've been thinking of it, and the way that we have been going about reporting. And then there at the bottom, you can see an increase in indirect COVID-19 deaths. That kind of comes back then to the indirect deaths, or the external deaths, things that increased during the pandemic, but were related to the pandemic only tangentially and not necessarily directly to COVID deaths. So I will let Betsy take it from there and kind of zoom back out again to just the idea of excess deaths.
Yeah, so you probably heard the term excess deaths before, but we really wanted to make sure that everyone was on the same page and just sort of understanding this concept. So the idea of excess deaths is something that's been used by epidemiologists and researchers in the past to look at the true impact of a particular health crisis, whether that is AIDS or opioid deaths or something else along those lines. The idea is that you basically have a modeling scenario where you estimate the number of deaths that would happen in a particular region in a particular year or month if the crisis had not happened. So we sort of think about like a fictional scenario where COVID did not hit the world in early 2020 and say how many deaths would have occurred if that crisis hadn't happened. And then you compare that modeling number to the actual number of deaths that did happen. And so the difference between that sort of estimated, here's how many deaths we would have had without COVID, and the actual deaths that did occur with COVID, that's what we call the excess deaths. So this chart from The Economist that I think kind of paints a good picture of this, you can see the excess deaths globally in red, and then the gray line below is the actual number of COVID deaths that have been reported. So as you can see, there's a pretty big gap between the excess deaths, which are all of the deaths that occurred that are sort of above the average that we would expect, or above the number that we would expect in 2020, 2021, and the actual COVID deaths that are reported. So that gap, which we call the unexplained excess, sort of poses a lot of questions for reporting. We can ask how many of these unexplained excess deaths were actually COVID deaths that were not correctly identified, or we can ask what are the other causes that contributed to this huge increase in deaths, basically. Yeah, I think that's it for this slide. I would also say definitely go check out the Economist charts on this, because they have their own sort of modeling to calculate excess deaths, both globally and in different countries and within the US. So that's a useful source to check out if you sort of want to understand this topic more. And then as a resource for other reporters who are working on this topic, our team has put together a data repository. So far, it's mostly focused on the US as a whole and state by state data. So it's primarily relying on the new CDC mortality data that we're going to talk about more later. But we also have some figures from the Department of Justice that talk about different death investigation systems in different states, a few figures from the census, and figures on excess deaths that come from modeling done by the Boston University team of researchers at Boston University, one of whom, Andrew Stokes, is on this call, and I think will be able to help us answer questions later if folks want to ask about that more specifically. And then the link is in the chat if you want to go check out the data repository, sort of click around and ask us questions later about it.
And one quick addition here. So the top line, you'll be able to see with the repo some of the top line columns that go through cumulative pandemic deaths per capita, normalized figures, excuse me, and modeling figures. But you'll also be able to see causes of death. We've picked out 6 or 7 major causes of death from the thousands of ICD codes, they call them, from the CDC. And we've also been sort of toying with how to make this data clean and easy for people to use, hence why we're using a Google Sheet. But you'll notice some color coding. When something's flagged as orange, we've determined that one is with a population or a pool of people that is above 100,000 or more, and 2 is 1.5 times greater than the national average. So for us, that's a clear sort of bad metric for that state or the country writ large. So that's why we've coded it as such. And there's a little bit of a README at the beginning of the repo that goes through each column and describes the source and what's included and the date that it was updated, which is important since these are being updated bi-weekly. And thanks, Betsy. That's the data repo again is here for anyone. And we'll go back to Dylan for how medical examination and coroners work.
Yeah, for me, this is a really important question because this, once I actually started reporting on this, was probably one of the most confusing things to me. Because, I mean, unless you've worked in a medical profession or had a loved one close to you who may have died at home or in a setting that is not a hospital, you may just kind of think that most people die in hospitals. And that is true. About 30% of all deaths happen inpatient, and then 30% also happen at home. And then the last 40% is kind of a mix of ER, outpatient, hospice, long-term, and nursing home care facilities. So those last 4 categories are kind of around 10 or so % each. But the bulk of deaths either happen at home or in a medical facility inpatient. And that's kind of where the differences on how those deaths are investigated begin. When someone dies in a medical facility, it's what one would call an attended death. So there is likely an attending physician there who knew of this person's health and possibly terminal illnesses or something like that before this person died. And they can do a chart review looking at this person's medical history to then work to the underlying cause of death. When someone does not die in a medical facility, say when they die in an accident or at home or in some other circumstance, that is where the medical legal death investigation comes into play, and that is medical examiners or coroners, depending on the state and then the county within the state. And medical examiners, most of the time, do have a background in medicine or are also certified as well, whereas coroners are often elected with very little background. Medical examiners, on the other hand, are also appointed. So there's very big differences depending on where you die in how your death investigation or how that death is then investigated afterward plays out. But it's a big difference between dying at home and dying in a medical facility or somewhere else. That becomes important later on when we're thinking about what types of deaths may have went missing as COVID deaths and why they weren't properly investigated or what information may have been missing.
I'll also add that you might notice in the data repository, one of the first columns is for each state, we have the type of medical investigation system that they have, whether it's a centralized system or whether it's individual coroners or medical examiners at the county level, because that's an important piece of context for each state.
Yeah, and that takes us to the next slide, which is an avenue of reporting that I've been specifically interested in after a lot of conversations with Andrew Stokes, who is also on this call, and again, will be able to answer some more questions about modeling after this conversation or after the webinar. But yeah, so once you're looking through CDC Wonder data, you can start to identify specific places to look at causes of death by place. And one really important thing that we've seen is that at-home deaths are at about the same proportion they are year to year in 2020 as in previous years. But a lot of natural causes of death are going up at home, such as heart and lung disease. So when you take that into account with the fact that a lot more deaths happen at home than one would expect, that is a significant amount of people during the pandemic who are dying more from heart and lung disease at home than in previous years. For example, in Louisiana, one of the places we've done a lot of reporting, deaths at home increased about 30% for hypertension, diabetes, and Alzheimer's, which when those deaths are combined, those increases are combined, is quite a high number of more deaths from natural deaths than usual. And the really important part of that is also then when you compare these increases from natural causes back to, say, increases for external causes, they end up being even more. So while there is a significant proportion of excess deaths that have happened for external causes, like unintentional drug overdoses or increases in homicides, these steady increases in natural causes even outpace them once you start lumping the natural causes together, because these are already the leading causes of death. Most of these, like hypertension, diabetes, Alzheimer's, are leading causes of death at large, but even more so at home. So large increases in those types of death affect, I guess, the larger sample that we're looking at when we're talking about increases in different types of death during the pandemic.
So another avenue for reporting based on the CDC's mortality data is looking at demographics, and specifically looking at the disproportionate increases in deaths among people of color in the United States. Because of course, as we all know, people of color have been harder hit during the pandemic than white Americans. So one example, and probably one of the greatest increases that we've seen in looking at these data, is that among Hispanic and Latino Americans, there was a 40% increase in all-cause deaths from 2019 to 2020. And even though we don't have complete data for 2021 yet, we're missing the last couple of months, there was still an increase from 2019 to 2021 so far. So this is definitely something that you can look at in your state or in your county and sort of seeing how these demographic changes have shaken out and what avenues for maybe asking further questions there might be. And then a couple of notes on our data repo on this topic is that the CDC Wonder system classes race and ethnicity separately. So what that means is that you can search for different race categories, which are the main ones are white, Black, Asian, Native Hawaiian, Pacific Islander, and Native American or Alaska Native. Those categories are sort of provided separately from Hispanic, not Hispanic. So if you want to do different searches, you have to sort of be aware of that and figure out if you would rather search for one or the other, or if you want to search for both, and then sort of adjust your calculations. So in our data repository, I've done some sort of very basic summing so that you can see all Hispanic for a particular state and then non-Hispanic values for the other race categories, just to make it a little bit easier to work with, essentially. But because of this, the death rates in our repository, which are deaths per 100,000 people, are not age adjusted. So you might notice that the rates for most of the non-white categories are lower than the white category. And that's because we tend to have a lot of white Americans who have a longer life expectancy. So they might have a higher sort of crude death rate simply because you have more people who are dying at older ages, and that sort of skews the numbers. And demographers will often use what they call age-adjusted death rate to sort of make better or more representative comparisons. But that's not something that we've done in our repository just because of kind of the limitations of the CDC Wonder data. And that's also why it might be helpful to look at increases from 2019 to 2020 or from other previous years to the years during the pandemic, rather than sort of comparing those crude rates, if that makes sense. And yeah, definitely ask me about this later if you have more questions, because it's a little tricky to wrap around.
So yeah, I will take it this slide. Again, when we're narrowing down what I've talked about before of indirect causes of death and direct causes of death related to the pandemic, the specific types of death to keep an eye out for when you're looking through the data on your state or local county span from flu, Alzheimer's, diabetes, stroke, respiratory, other heart diseases. Those are all the kind of natural causes that I was talking about earlier that are worth keeping an eye out for. Again, especially at home, as one epidemiologist in Jackson, Mississippi told me, if someone's 60, 70, 80 years old and they died and had maybe Alzheimer's or diabetes or other respiratory diseases beforehand, that's what you're likely going to find on their death certificate. A death investigation for those types of people who had COVID at the time is going to have to be very thorough, whether in postmortem testing or autopsy. And unfortunately, not a lot of those folks get that, especially at home deaths or in rural counties where coroners don't have the type of resources to do those investigations. So I just kind of wanted to note those as specific causes of death to keep a lookout for.
And I'll talk a little bit about motor vehicle deaths, but Mohar has also done quite a bit of work on drug overdose deaths, which might not be directly tied to COVID, but are certainly right, certainly indirect COVID deaths. With motor vehicle deaths, there's been some good coverage recently. The Los Angeles Times just came out with a pretty compelling piece on some of the reasons why motor vehicle deaths are increasing in the pandemic, and also looking at some of the NHTSA data that's available, which looks more at the number of motor vehicle crashes and fatalities, but does not necessarily take into account some of the CDC data. We've gone ahead and cleaned some of that and only looked at transport or motor vehicle deaths with a passenger or occupant or driver involved with a stationary object or another vehicle, but that also includes pedestrians. So our numbers are a little bit larger than what you might see with NHTSA. These deaths are comparatively compared to, say, heart disease, which is 600,000 Americans die in 2020 from heart-related disease. This is a relatively smaller universe of 45,000 Americans that died in 2020 and looks like 2021 as well. But the increase in motor vehicle deaths are concentrated among African Americans and specifically Black men. One compelling data point, which we'll talk about later, is the number of motor vehicle deaths, excess deaths in urban areas, especially. We looked at Detroit, Wayne County, we looked at Cleveland, we looked at Chicago, Cook County, and New York City, and saw similar trends. So it's worth digging into that as well.
Right, so on the drug overdose deaths, with the CDC data that came out, we have the opportunity to look at deaths that are classified anywhere between ICD X40 to X44. So those are all accidental drug overdoses that are, so that's unintentional drug overdoses. We can combine these codes with contributing causes of death to find, which are called T codes, to identify opioid-related deaths. These are deaths that sort of fall under the umbrella of excess deaths, but may not necessarily be explainable due to COVID. Back in March, earlier part of the year, we were looking at some counties in California which had large excess death counts, and found that a good number of that were because of fentanyl overdoses, a trend that had been continuing since a spiking trend that had been continuing since 2019, but with all the furor over COVID, those deaths were underreported. So that's also a pretty decent avenue for reporting. We found that for drug overdose deaths, you can those numbers can be undercounted at the state level or at the county level, but the CDC data allows you to cross-reference those numbers to find counties that might be worth looking at.
So yeah, that is right there. What you're looking at is the screen that you will see once you find your way past the CDC Wonder main page, past I think another 2 pages. Maybe you get asked what year, and if you're looking at multiple underlying causes of death or just underlying cause of death from previous years or from 2018 to current. Then you click the data use agreement and say that you agree. Thank you, Betsy, for putting that in the chat. You get to this kind of graphic interface way of interacting with the Wonder data. Just a plug here, I have not heard back from the Wonder technical team about getting API access to that. If anyone here would like that, it would probably be worth annoying them as well, because there are a lot of great things about the Wonder data, but it is hard to make all these individual calls just using the drop-down graphical interface. So if there are any other journalists on this call who would advocate for groups of journalists or individual journalists getting API access, I think the more people that annoy them, probably the better. One of the big problems is what we're going to talk about in a few minutes, which is some of the caveats that come with CDC Wonder. One of them being suppression of any values under 10. So again, as we're just like looking at this this table layout, there's a lot of ways you can slice and dice Wonder data, from race and demographic type of things into age, into geographical settings by county, by I think by urban, like metropolitan groups, by lots of different kind of ways that you can that you can imagine, and also by setting. So if someone died at home, like we've been talking about, or somewhere else, like in a nursing home facility, or inpatient, or ER, or dead on arrival, or I think there's even just an other category that you can search through. You can also click whether you'd like to see that those deaths in the groupings that you've identified were autopsied, or what percentage were autopsied. So there are a lot of different ways you can organize your search. Again, the only thing to keep in mind is that if you get too specific, you might run into the suppression of values under 10, which I think is because at least one state, I think it's the state of Texas, has an agreement with the CDC not to share values under 10, and so that sets the baseline for all of the data that the CDC releases in this Wonder data set. So if you get a little bit too specific, you'll hit the suppression of values under 10, and you won't be able to see that. But that being said, again, there's tons of different ways to slice and dice and analyze the numbers. You just have to be aware that if you get too specific, you may be looking at something funny, or if, say, you start comparing the numbers that you get to the total numbers, things might not add up quite the way that you expected, because there are numbers in that search that were suppressed. But if you scroll down, which I think this is just a static picture right now, but if you scroll down to the bottom of your search, you can also click a little box that says show suppressed or zero values, and that'll be really useful as well. But I think Betsy is going to talk a little bit more about tips.
Yeah, so Dylan talked about the suppression already. That's definitely a very important thing to be aware of. And sort of on that note, you might find it helpful to start with more broad searches and then narrow it down. So for example, if I wanted to look at deaths among the Native Hawaiian or other Pacific Islander community, which is a smaller demographic group, I might start with a national level where you would not have any suppressed values because everything would be over 10. But then when you go down to the individual state level, and I did find this when I was looking at demographic data, there are some states where there's simply not a large enough population of that demographic in the state. So the number of deaths is under 10 or 0. We don't know exactly because it's suppressed. So maybe from there, you might go down to the county level in a particular state, depending on what you're researching. Another piece of advice we have is to make sure you read the documentation for the data set. It's pretty extensive, and depending on what field you're looking at, you might find that really helpful. And also to just practice, spend some time with the tool and make sure you know what all of the different fields are. And then it's also important to be mindful of what the Wonder system calls residence versus occurrence. So the residence is where someone lived before they died, whereas the occurrence of the death is where they died. So for example, maybe you have someone who lived in rural Idaho, but then when they contract COVID, their local hospital is full, so they're sent to Washington State for care. So the residence of that person would be Idaho, but the occurrence of their death would be Washington State, right? So you'd want to make sure that you know what you're searching for, and that when you ask Wonder to sort your data by residence, then you're also selecting specific states by residence, or the other way around. And then the last piece of advice we have here is when you export data out of Wonder, it will save in a text file that you can copy into the program of your choice. It's important to hold on to the notes section because that will actually tell you exactly what you searched for, and that makes it very easy to replicate the same searches or do similar searches later.
I'll just add that I had been deleting that notes column for a long time until Betsy told me that there's actually something useful there, and have now started saving it just because it's good documentation to have.
For sure. It really does help you put together your readings too. So this slide is about sort of practically how do you go from a very national overview, how do you winnow that data down to a local level. And so this is the methodology that I use for drug overdoses. So we'll sort of go over that. So what I usually do is I use CDC Wonder to get the state-by-state numbers for any mortality statistics inquiry. In this case, let's say I'm looking for causes of death between X40 to X44, which oh, sorry, can you hear me a little bit better now? Is there an open mic? Much better. Okay, wonderful. Sorry about that. I didn't realize my microphone was so poor. Yeah, I'm at a restaurant. But in any case, what I was saying is you get the state-by-state numbers for your mortality statistics inquiry. And what you can do then is if you pull that data for, say, 2019, 2020, and 2021, you can calculate percentage rate of change. And then that's an easy numerical metric that you can use to sort the states. And that will allow you to look at the largest increases, say, in drug overdose deaths. Now you have a few specific problem states or a few specific states of interest to look at. Now you can pull county or census tract level numbers for the entire country from the CDC. For the same mortality inquiry. But instead of having to go through all of that data, you calculate the same rate of change number, that numerical metric, for the local level that you've pulled. And I'll caution you that at least census tracts and even county names can change year to year. So you want to make sure that you're joining the right county with the right county, like you're comparing the right county with the right county when you calculate that rate of change. So when you do that, and you sort, now you have this massive list of local numbers, but you get to basically pick out the counties in the states, which one aggregation level up, those are the states that you need to look at. And also you want to make sure that at the county level, some mortality inquiries can be dealing with really small numbers. So you want to make sure you're looking at slightly significant numbers. So for example, so a death count that goes from 5 to 10 is a large increase, but that's not maybe significant. So you want to look for slightly larger numbers than that, maybe over 100. So in this case, some reporting that came out of this process was that we saw that several states, California, West Virginia, Maryland, Kentucky, Mississippi, Louisiana, saw really large unintentional drug overdose deaths in 2020 alone and large rates of change. And from there, we were able to see that Berkeley County in West Virginia, San Bernardino County in California, Baltimore County and City in Maryland, Charleston, Denver, Tampa, these are specific local hotspots for unintentional drug overdose deaths. And from there, you can say Baltimore, Maryland, which had one of the highest increases over the national average. You can pull opioid reports from the Maryland Health Department and check what their count for opioid deaths for unintentional drug overdose deaths are. And that sort of allows you to cross-reference your findings. So that's one way of winnowing from the national level to the local level. And I'm happy to answer questions on the process.
Awesome. So a few other tips for reporting once you've kind of taken a look at your local state or county or region in the CDC Wonder system or in the mortality data. A few things that you can do. You can look for potential uncounted COVID deaths, which may be excess, like I mentioned, that unexplained excess value, deaths that are higher than you would expect to see in 2020 or 2021 had the pandemic not occurred, but they're not officially reported as COVID deaths. So you can look at that difference and see, okay, was there an increase in respiratory deaths or an increase in deaths tied to cardiovascular disease that weren't labeled as COVID, but maybe they could have been, COVID could have been related, but wasn't on the death certificate. At the same time, you can look for deaths that might be indirectly tied to COVID. Like Mohar mentioned, drug overdoses are one example of that, or other deaths that might have been tied to a lack of medical care because hospitals were overwhelmed with COVID patients. You can also learn how deaths are investigated in your state or your county. That one column in the data repository that has the death investigation system by state might be kind of a useful starting point for that. But then you can see, okay, does your county have a coroner? Is there a medical examiner's office? And can you talk to those people and ask them about their experiences during the pandemic? I think this has been a major part of our reporting process for the investigative stories that we've been working on this topic, is actually talking to the people who are doing this work. And then in addition, you can talk to epidemiologists or other researchers who know the region and can say sort of what are some of the major causes of death, prior to COVID, what have they been seeing during the pandemic, how are they understanding the CDC's numbers, and you can kind of get that expertise in interpreting the data. And then a few notes on our data repository. So one of the really kind of unique and exciting things about this release from the CDC is that typically for data to go into the CDC Wonder system, there's a lag of over a year. So in a normal circumstance, they would be finalizing the data from 2020 right now, and it would come out sort of early 2022 sometime. But due to all of these sort of importance of getting more COVID data and enabling the research that we're all doing, they've actually released provisional 2020 data and 2021 data so far already. And so although that data is available earlier than it would be otherwise, you have to keep in mind that it is provisional and that the CDC team behind this data set is going to keep updating it throughout the coming months. So right now, the 2021 data include deaths occurring through November 20th. Also, if you might have noticed in our story, those numbers were based on data through October 23rd. The CDC actually updated the Wonder data over the weekend. So now it's through November 20th. And we're going to expect them to keep updating it every couple of weeks until the 2020 and then eventually the 2021 data are finalized, probably within another year. So we'll keep updating it. We're also anticipating adding county level data, but right now it's just state level
data. We also wanted to sort of step back from all of the data points that we're flagging here and some of the notes and sort of give it just a few concrete examples of how you can take the data. Mohar mentioned this when she was talking about drug overdose deaths, but it's important to think in terms of how these stories can be reported out at the local level. One very clear, very straightforward approach to this is what Mohar alluded to, which is taking one's state's causes of death for the entire pandemic grouped by year and figure out the broader trend lines. So drilling down deeper into the biggest year over year or the biggest pandemic versus pre-pandemic increases and pinpointing which communities, which counties or regions or demographics, and whether that's race, gender. There's also 1, 5, and 10-year age groups. Obviously, the more you drill down into that, depending on the population size, the more you'll run into suppression issues. But if you do a 10-year age grouping, which can be quite helpful for figuring out the number of men between the ages of 35 and 44 who are dying of drug overdoses or motor vehicle accidents. That's a good way of taking what is fairly faceless blank numbers and turning into real people and understanding sort of how it affects specific communities. Story idea 2, again, this is well known to most public health experts, but it's worth repeating because these are important data points. Certain non-COVID causes of death are near record highs again in 2021. So we already have an early look at 2021. There's a lag. There's 2 months of lag to begin with. And then on top of that, there are about 112,000 deaths that have not been fully reported out cause of death because of a 6-month lag in the death certificate process. There's also a huge increase in one of the well-known garbage codes, or a code that shouldn't be used by a medical examiner, and that's probably a fill-in. code in order to for a coroner or a medical examiner to push that death certificate aside and work on the influx of deaths they're seeing. So all that's to say, the 2021 data is very early, very provisional, very incomplete. But if you're already seeing increases in diabetes deaths at this early point in 2021 versus any other year on record going back to 1999, that says something. And it will only go up, obviously. So, and the winter time is actually the worst time seasonality for deaths in the United States, November, December. So these are things worth flagging and thinking about and talking about. Overdose due to opioid and fentanyl, you can actually now look with the CDC Wonder tool, look at multiple causes of death. So on a death certificate, there's one underlying cause of death. For statistical purposes, that's one code. And then you can put up to 20 others on the other lines of the death certificate for immediate causes of death. So that means you can have up to 21 different codes on one death certificate. So that presents a very revealing and interesting data point in multiple causes of death, but very messy, because one person might just have, one or two codes listed. Another person might have 21. And unless you get the record level, the specific information on one person's death certificate, it's hard to separate that out. But the multiple cause of death query can be a great way at understanding the larger trends. So if you're seeing a lot of medical examiners or coroners in Baltimore City writing in overdose due to a synthetic substance, but not really identifying opioid, and then the state doesn't group that as opioid deaths, but they probably are. That's a good leading indicator of something amiss. It means the Baltimore City and county figures are off, the state numbers are off, and the CDC numbers are a little bit clearer, but still lacking. So again, you're dealing with data points that are say something, but require reporting to fully flesh out. Same thing for motor vehicle crashes. We already talked about that. We just mentioned diabetes, which is going to be, I think, a pretty important story, especially on the heels of some new research looking at how COVID infects fat cells and obesity. General questions to think about: what communities are faring the worst and why? What communities are doing well comparatively and why? In Florida, one of the worst hit communities in terms of diabetes is Miami-Dade. And within that, communities of color are hit disproportionately worse, and men in particular. So why? Why is that the case in Florida? And then 3, I mentioned this briefly. I'm not going to belabor this. We have a reporting recipe that will go out that will explain this. But garbage codes are a group of, say, about several hundred causes of death out of many thousands that are deemed by the WHO and the CDC to be off limits for underlying cause of death. So that final cause of death, that one line, these codes are not supposed to be included there. There's a lot of reasons for that. They're not very specific. They're vague and they're lacking in detail, and they don't really say much. But yet they still make their way onto death certificates, mainly because probably people that are reporting those cause of death, whether it be a coroner or a funeral home or a someone else with reporting capacity in a given place, have been using it for a decade or several years, and they feel like it's a legitimate cause of death. That's what we heard from the Florida Department of Health. In Tampa area, there is a large number of deaths coded as senility. Senility is not an underlying cause of death. It can be used elsewhere on the form, but senility itself is not the chief reason people die. And yet in Tampa, it's been used over 100,000 times over the past decade, and it's being used quite a bit in recent years. And when we talked to the regional medical examiner there, and we talked to the state health department there, they told us frankly that they're not the ones doing it. They would never do it, but they don't have the oversight or the capacity to figure out why that's happening. And at scale, that represents a problem, because you have a bunch of deaths that shouldn't be coded as such. And it skews the numbers, and it skews resources, and it skews the overall impact of diseases like heart disease and COVID. So again, just worth thinking about. We have a list of garbage codes in our most recent story that we flagged that are the most awfully used. Questions, you can email us at info@documentingcovid19.io. You can also check us out on Twitter, and we have a few stories on this topic. We'll also have, I think, a larger project launch on this next Tuesday, if all goes well. And happy to answer any questions. I'm just looking at the chat here. Okay, I think I see one. Mary Catherine, what advice do you all have about selecting the appropriate option for viewing different causes of death through the Wonder query? For example, under underlying cause of death, there may be a dozen different options, and I don't understand the differences between them. Dylan, you've been messing with this for quite a while. You want to take that?
Yeah, I mean, it depends what level you're looking at, whether county or state or nationally. There are kind of three options you have. You can go directly for the underlying cause of death. You can go for the chapter or the subchapter. So sorry, in order, chapter, subchapter, underlying cause. I find moving through those to be pretty useful. So if you started at chapter, it might make more sense. And then you identified a chapter you're specifically interested in. And then finally an underlying cause in that chapter or in that subchapter. And you can kind of see that as you search, and you can also see it in the kind of the pre-search window. So I would recommend actually not going straight for the underlying cause, but maybe first taking a look at the larger chapters that just say respiratory deaths, for example, and then identifying a subchapter and underlying cause. When I'm just kind of looking for myself, just quickly seeing what trends are, I actually think subchapter is the most useful, especially at a county level, because once you get to underlying cause, that's such a specific code that you may run into suppression problems, and just for aggregating purposes to see general trends, the subchapter is probably actually the most useful. And then if you want to see the underlying causes of death, then searching for those as well after.
Great. One thing I'll flag on that as well, the underlying causes, I mean, they have a grouping for ICD 110 and 113 for infants. That's like a smaller sort of grouping of the larger number of several thousand codes that can be helpful. But the subchapter is a really good way of grouping this. They will combine codes that they have deemed to be relevant and grouped appropriately. So we found that we also, in our README in the Google Sheet, we've grouped some of those codes for you based off of what the CDC has grouped in some of their releases for year-over-year statistics. Without any other questions, thanks, Andre. Any other takeaways, Dylan, Betsy, Mohar, from the data that you've found that you wanted to flag, or things that might be interesting to look at as we get more and more releases?
I think we did a pretty thorough job.
All right. All right.
I think we covered so much, in fact, that we might have lulled a few people to sleep. So hopefully everyone was tuned in for all of that information.
All right. Well, thank you, everyone. We'll close up early. If you have any questions, please email us. You can find us on Twitter. Check out the website and the data repo, and look forward to future releases.
Yeah, and if you end up using the data or using our reporting recipe, let us know.
Yeah, and I'll just say again, I think we're all super responsive to Twitter or email, and happy to talk, answer questions, bounce ideas, everything.
Thanks, everyone.